welcome here. Welcome to my virtual audience as well. Wow. Hopefully this technology is going to work for us today. My name is Jeannie Rosner. I am the founder and organizer behind Soul Food Salon, where our goal is to educate and empower us all to live healthier lives. This is starting our 9th year. So some of you have been here before, all through the COVID with me, and so I appreciate your support. We have a website, soulfoodsalon.com, where everything that we've done in the last 9 years is there. You can access past presentations. We have a YouTube channel, Soul Food Salon. Many of our salons have been recorded. This salon is being recorded, as well as live stream and the live in-person event. So you can access that whenever you want. I'm pretty active on social media. It's at Soul Food Salon, mainly Instagram. I'd love it if you would follow and share it with your audience. My goal is just to spread the message to more people to live healthier lives. So each year, we partner with a different nonprofit. And this year, we are partnered with Eat Real. And the executive director, Nora Latore, is here. She's going to give us a little synopsis of what they're doing and what we're doing with them. So Nora, can you come up?
First, I just want to give a huge thank you to Jeannie. You are such a visionary in the space, and you are truly, I believe, raising the bar for what our food system can look like and what health can look like in America. And I love learning from you. I love learning with you. And our nonprofit is super grateful to partner with you. So our nonprofit was started by some leading doctors and pediatricians that truly wanted to upstream health in America. They saw what was happening in terms of public health and that we are actually getting sicker. The latest stats are that 93% of Americans are cardiometabolically sick, which we're going to hear more about the importance of cardiometabolic health in a moment. But they saw the writing on the wall, and they saw that our kids were getting sicker. As the richest nation in the world, we believe that every child has the right to a long, healthy, and happy life in which they can reach their full potential. And so that's why our nonprofit was started, to do policy and advocacy, to do awareness building, and to transform our food system so that it's healthy for every single child. And so this year we're partnering with Soul Food Salon, and our goal is that we bring our program, bring real food to over 500 schools across California and the nation. And right in the backyard here, where we are in Silicon Valley, we're partnered with Morgan Hill Unified. And so this year with Soul Food Salon, we're raising funds at ereal.org/soulfoodsalon. You can find out how every donation helps support this food systems transformation. But we're raising funds to help support local kids to have access to healthy, delicious, sustainable, culturally relevant food. And we truly believe that if we can get kids the food that they need to learn, grow, and thrive, then we are going to upstream health in America and create more public health resiliency. We can help pandemic-proof society, and we can really give every kid a chance to live their best life. And so we would be so grateful if the people here and the people listening could support this goal that Jeannie has set in terms of helping us reach 500 schools. And you can do this. The people in this room have the power to help transform. It would transform 120 million meals this year. So if we achieve our goals, then this year alone, 120 million meals will be healthier and more sustainable and made accessible to kids here and across the nation, but especially in your backyard, where there's in a land of abundance, and there's a lot of food insecurity and nutrition insecurity. Jeannie has my contact information. You can reach me on LinkedIn, Nora Latore. You can reach out on eatreal.org. we need support. We're a small but mighty nonprofit that's really fueled by our volunteers and our supporters, and we really need your donations as well, because it determines how many schools we can admit into our program. And we have over 2,000 schools on our wait list. So thank you for helping us create a healthier future, and I'm really excited to continue to learn with you, and thank you so much, Jeannie.
So today I have the pleasure to introduce Nicole Harkin. She is a preventive cardiologist who has more board certifications than many people have, okay? So I had to write it down because I would flail probably. She's board certified in internal medicine, cardiology, echocardiography, nuclear cardiography, and clinical lipidology. It's a lot of board certifications. For anybody that's ever gone through the board certification process, this is hats off to you. She's now working remotely in a telemedicine concept with Preventive Cardiology. And today she's going to provide for us tips on how we can maximize our own cardiovascular health. So I leave it to Nicole to share her wisdom with us.
All right, thank you so much for that warm introduction. It's so exciting to be here and in front of a live audience. I was just telling Jeannie, this is, I think, with the first talk I've done in a very, very long time in front of people instead of virtually on a screen. So it'll be great to be able to have audience reactions and things like that. So I wanted today to really walk through with you sort of why we need to care about cardiovascular disease, why is it important, and what are the big levers that we can pull? What can we do to optimize our heart health? So I'll focus a lot on nutrition, simply because that is one of the bigger levers that we can pull, but I will quickly go through some other things as well. Feel free to, this can be kind of a conversation. I welcome questions whenever it feels like it makes sense. We can also do kind of a Q&A at the end, however it ends up making sense for everybody today. First of all, why should we care about cardiovascular disease? Hopefully most of you know that cardiovascular disease is the leading cause of death globally in every country, every sex, every ethnicity. It is quite simply the top cause of death. And this relationship persists even in the setting of COVID. So here I'm showing the death rates in 2019 and 2020. And you can see that even with COVID, heart disease still was the top cause of death, followed by cancer and then by COVID. As I mentioned, it is the top cause of death in women as well. This is hopefully increasingly becoming known, but it was previously a fairly unknown fact. And given that we are all females today, here at least in this audience, it's a good thing to walk away from. I also want to point out that it's not just something that happens, unfortunately, as we get older. Yes, age is one of the top risk factors for heart disease, but unfortunately, almost half of all heart attacks in this country occur in individuals under the age of 65. And that actually, unfortunately, in that age group, that the rate of heart attacks is increasing. While this is all very sobering statistics, luckily about 80% of heart disease is thought to be preventable. So just very briefly, so we're all on the same page, what is heart disease? So heart disease is sort of a catch-all term for any disease of the heart. So this could affect the valves, this could affect the pump function, but really when we're talking about heart disease, colloquially, most of the time we're referring to blockages in the artery or coronary artery disease. So what is this process? It's technically atherosclerosis, which is a buildup of cholesterol in the arteries. How this occurs is cholesterol is contained within these little vehicles called lipoproteins. And what they do is they transport cholesterol throughout our bloodstream and deliver different things, proteins and things like that, that our body needs. The biggest driver of if these particles get from in our bloodstream and into the artery wall is really that concentration. So the higher the number of particles that you have in your bloodstream, the more likely that it will deposit into the artery wall. I also wanted to highlight endothelial dysfunction. This is the process by which the vessels become damaged. And this can occur whether it's through smoking, insulin resistance, or diabetes, things like that, inflammation, that make it more likely that those lipoproteins will infiltrate the vessel wall. So what you can see here is the process of atherosclerosis. As it starts to build up in the vessel wall, it will start to increase in size. If it gets so large, this can actually cause something called obstructive coronary disease. This is what you typically think of when someone's starting to have angina or chest pain or shortness of breath. The other thing that can occur, which is oftentimes more devastating, and this actually can occur even when it's not very large. So even at smaller sizes, the plaques can actually rupture. When that happens, that's what's known as a myocardial infarction or a heart attack. So who gets heart disease? This is a study from the Inner Heart. It was a really, really large global epidemiologic study that was looking at why are people getting heart disease. And the things that are here on the right-hand side of this line are the factors that they identified as being the top causes of heart disease. What's not on here, so this is on a population-wide level. On an individual level, age is one of the most important risk factors. This is really just a function of the accumulation of the risk factors that we have over time. So sort of an area under the curve phenomena, if you will. That said, the factors that they identified, it's difficult to read, so I'll read them off for you. So current smoking, diabetes, hypertension, abdominal obesity. What that's really referring to is the visceral fat. So what we now know is that it's not just having excess weight. The weight, it's the subcutaneous stuff, the stuff we can all pinch. That's not the bad stuff. It's not the stuff that actually ends up leading to cardiovascular disease. It's really the excess adiposity that's around our organs in the abdomen. So that's specifically what they identified. Psychosocial index, so this is things like stress, socioeconomic determinants of health, poverty, all of those things that are a little bit difficult to capture, but consistently are shown here. And then lastly, this ApoB, ApoA1, essentially it's a fancy way. ApoB is another way of quantifying LDL particles, or those atherogenic particles that I described earlier. ApoA1 is a way of describing your HDL. So it's essentially that LDL to HDL ratio that probably many of you are familiar with. And then the things that emerge to be protective, fruits and vegetables, exercise, and moderate amounts of alcohol intake. I also just wanted to highlight over here that on an individual level, and things that I see every day with my patients, are some of these other things. Strong family history of heart disease. How we define that is a heart attack or stroke in a man under the age of 55 or in a woman younger than 65. Things like inflammatory or autoimmune conditions are increasingly being recognized as well. This is things like psoriasis, rheumatoid arthritis, lupus, early menopause, which is before the age of 40 or 45 in women, as well as pregnancy complications. So it's little known that actually preeclampsia, gestational hypertension, gestational diabetes, beyond being sort of an issue in the pregnancy themselves, decades later, they actually predispose a woman to heart disease. Kidney disease, chronic stress, and then sleep issues. So how can we prevent it? As I mentioned, it's thought that about 80% of heart disease is preventable, and I also just really like the study a lot because it highlights for my patients, particularly those who come to me with a very strong family history of heart disease, and this is a quite empowering study. So the study was published in the New England Journal of Medicine in 2016, and what they looked at was really this relationship between genetic predisposition for heart disease and lifestyle. And what they did is they divided this group of people up into low, intermediate, or high risk, which you can see on the x-axis there, based on their polygenic risk score. So they figured out a bunch of the different genes that we know that are related to increased heart disease risk, and they divided them into the low and intermediate and high risk. Then they looked at lifestyle. So the people that are in blue had a healthy lifestyle, and there they defined quite simply as just having a heart-healthy diet, exercising, not smoking, and having sort of an ideal body weight. And they found that even in the people who had a high genetic risk that I've circled there, lifestyle was associated with a 50% risk reduction in the development of heart disease. So this really highlights that genetics are important, but they're not necessarily destiny, and definitely how we interact with our environment can change our risk of developing disease. So what should we eat? So this is actually a table that I pulled directly from the ACC/AHA primary prevention guidelines. So this is sort of the national guidelines that every cardiologist, certainly, and most doctors should be familiar with. And we'll go through some of the evidence as to why some of these foods emerge as being more cardioprotective. So it emphasizes a lot of plants, vegetables, fruits, whole grains, legumes, nuts and seeds, and then fish as being what our diet should predominantly be composed of. And it recommends limiting, in particular, processed meats, refined carbs, and then sugar-sweetened beverages. But we eat food, not macros, so what does that actually mean? What the recommendations have described here within the context of this are different dietary patterns that fit sort of those different types of foods and macros and things like that. The Mediterranean diet, which probably many of you are familiar with, it is a fairly plant-predominant diet, rich in the heart-healthy mono and polyunsaturated fats, fishes, and lean meats, lower in red meat. The whole food plant-based or plant-predominant diet is one that is either exclusively or predominantly composed of plant foods. And then the DASH diet, which I'll describe for you in detail in a little bit, but is a well-described diet that is pretty similar to Mediterranean diet, a little bit lower in fat, and very, very well established at lowering blood pressure.
And the DASH diet stands for?
dietary approaches to stop hypertension. Okay, so what happens when we swap implants? And so what I think is interesting about all those diets that I mentioned and what we'll focus on today is how can we incorporate more plants into our diet, and why is this potentially beneficial? And so this is a really interesting cohort study, a large study looking at US healthcare professionals with at least one risk factor for heart disease. And what they looked at was different dietary adherence to different types of foods and what happens if you swap one in for another. And what they really found was that replacing animal protein with plant protein was associated with a reduced risk of dying of any cause, as well as heart disease. And it was really kind of small amounts, so just 3% of total energy intake when they swapped it out was associated with a 10% risk reduction of all-cause death and 12% cardiovascular death. And the all-cause is kind of that top group, and the bottom is the heart disease group. What I definitely want to highlight here as well, and this is very consistent in all the studies really that we look at, is it's that processed red meat, importantly, is one of the associated with sort of the highest risk, followed by unprocessed red meat, followed by egg, interestingly. So when I'm working with a lot of my patients, if a processed red meat, so those are things like hot dogs, bacon, deli meats, and things like that, if that's out salamis, if that's a huge part of someone's diet, we try to work on swapping some of those things out simply because of this relationship. The other trials that I wanted to highlight was the Preventive trial. So this is a really big trial that was released, also published in the New England Journal of Medicine during my training. It was actually one of the first trials that I came across as a cardiology fellow, and was just really blown away by the immense impact that diet can have on developing cardiovascular disease. So it was a trial done in Spain, and it looked at the Mediterranean diet, and it supplemented the Mediterranean diet with either olive oil, extra virgin olive oil, or nuts. And then it compared it to actually a sort of low-fat diet, which we sort of thought was like the thing at the time. And then it was a randomized control trial. These were the interventions, and then they followed them out for 3 to 5 years. And what they really found was this Mediterranean diet supplemented with extra virgin olive oil and nuts reduced the risk of cardiovascular events, mainly heart attack and stroke, by 30%. It was dramatic. And I vividly remember presenting this study for Journal Club, and this trialist, very prominent trialist who was in the audience, my attending that I looked up to, and I remember very clearly her saying, if this was a new drug, this would be a blockbuster, right? Like, that's how much of an impact this had. So that was a cool trial. And then one of these sub-analyses that I just wanted to highlight, what exactly within the Mediterranean diet is helpful. So they did this secondary analysis, and they actually broke them up into sort of a pro-vegetarian food pattern. So they took all the individuals that they had in the initial trial, and then they kind of broke them up into those who were eating a lot of plants versus not as much. And as you can see here, when they looked at different quintiles of adherence to eating more plants, those in the highest quintile up here had a lower risk of mortality than other ones. Okay, so why might eating lots of plant foods be helpful? They're very high in fiber, micronutrients, and antioxidants, all of which are extremely helpful for our heart health. They're naturally pretty low in calories, as well as saturated fats, with exceptions, which we'll get into. And cholesterol, also added salt and sugar, again, all things that we'll get into. And so the Preventive trial was so seminal because in the nutritional literature, it's pretty rare to have these large randomized controlled trials. They're expensive to do, and they're very difficult to do. And so most of the trials that we have are shorter term randomized controlled trials or epidemiologic studies. But in our shorter term randomized controlled trials, we see in general, when people end up eating more vegetables, fruits, whole grains, things like that, we see reductions in cholesterol, blood pressure, insulin resistance, weight, and then some of these emerging markers that we're really increasingly realizing are very important in the development of heart disease. So inflammation, like I mentioned, and then TMAO and how it interacts, that's a gut metabolite. And so when we alter our gut microbiome, we end up having different byproducts that are formed, which are then very strongly associated with the risk of cardiovascular disease. So let's spend some time on LDL cholesterol. It's really one of the biggest sort of things that we can do to alter our risk of heart disease. It is causative of heart disease. It's not the only thing, but it is really quite important. And so really, as I mentioned, the development of atherosclerosis is because of these large number of particles infiltrating the endothelium and building up into our arteries. So if we can suppress our LDL cholesterol levels low, it's very unusual to then develop coronary artery disease. What's the goal? So in general, the guidelines will recommend below 100 milligrams per deciliter for the average risk individual. If you have heart disease, it should ideally be below 70 at least. But one thing I wanted to highlight is this interesting study, and there's been more and more calls lately for modifying these goals. Why? So this was a really interesting study. They took a bunch of middle-aged individuals, no known coronary artery disease, no risk factors for heart disease. And they measured their lipid levels as well as a bunch of other things, and then they went looking for atherosclerosis. So they looked for it in their heart, in their arteries of their neck, in their legs, in their belly. What did they find? Not unsurprisingly, individuals who had higher LDL levels in the 130s, 140s, 150s had pretty shockingly high rates of evidence of buildup in their arteries. What was more surprising to a lot of us was that even in these levels where we thought it was pretty good at goal, they still were seeing levels of buildup. And so it's really not until you get down to the 60s, 50s that there's really hardly any buildup. Now, this doesn't mean that everyone with an LDL of 100 is going to develop it, but it does give us a better context into how can we think about LDL cholesterol levels, how low should they be for everybody, and that's going to be different, based on your risk factors, based on your family history, et cetera. But all of this is to say is that lowering LDL is really one of our top priorities in terms of reducing our risk of heart disease. So diet's one of the biggest ways that we can change LDL cholesterol. Unfortunately, exercise, it's great for your heart, do it, but it does not modify LDL cholesterol all that much. It's really what we end up eating. So what we know pretty robustly from these metabolic ward studies, so basically we lock people into a hospital, healthy volunteers, they stay there for a couple weeks, and then you feed them specific foods and then see what happens to their bloods. And so we know pretty conclusively that lots of saturated fat, which is predominantly found in animal products, although I do want to highlight coconut oil and palm oil are very high in saturated fat. That raises our LDL cholesterol. And from these metabolic ward studies, we actually know that if, other than trans fat, which is by far the worst and is luckily mostly out of our food system at this point, when you swap saturated fat in with other macros, what happens? By far the biggest bang for your buck you get is swapping it in with polyunsaturated fats. So those are things like your fishes and some nuts and seeds, followed by monounsaturated fats, so things like extra virgin olive oil and avocado, and then lastly, complex carbs. You do not get LDL lowering if you swap it in for refined carbs, which is unfortunately what has happened in our food supply. What lowers LDL? Fiber. So fiber is our friend. Probably most of you are pretty familiar with fiber. It is a non-digestible carb. It's found in plants, beans, things like that. And specifically soluble fiber is what helps lower your LDL cholesterol. And so all plant foods have two types of fiber in them, the insoluble and the soluble. It's simplistic to think about it this way, but essentially the insoluble kind of helps you poop, and the soluble helps lower blood glucose and cholesterol. And so these are the recommended amounts for men and women that we should be consuming. On average here in the United States, we're consuming 16 grams of fiber. It's very, very low. I will say, however, and I'm going to show you this study in a moment, for goals of trying to actively lower your cholesterol or actively lower your blood glucose, you want to try to aim for even more. So they're looking at like 40 to 50 grams of fiber a day, total fiber a day. So this is a cool trial that, again, is one of the few randomized controlled trials we have on lowering biomarkers. It's a very cool diet that was developed by a Canadian physician. He published it in a number of years ago. It's called the Portfolio Diet. And essentially, he took a couple of different foods that he had noticed were really lowering LDL cholesterol, put them all together, and then compared them to a drug, actually. So I'll go through in more specific in case there's questions about what is exactly included in the portfolio diet, but essentially it's the soluble fiber I was mentioning, nuts, which are high in polyunsaturated fats, plant proteins, and then the sterols, which I'll explain in a moment. Essentially, he put all of that together, put a control group, which you see in these little open circles, on just a low saturated fat diet. So everybody was eating a lower saturated fat diet. Interestingly, they didn't see a massive reduction in LDL, but some, about 5%. And then he put someone on a low-dose statin. So one group in the boxes were on a low-dose statin. And then he had the triangle group eat the portfolio diet. And so he found a shocking almost 30% reduction in LDL with these addition of these foods, and it was equivalent to a low-dose statin. So this is the portfolio diet in particular. So as I mentioned, the soluble fiber. So all plants have fiber. Soluble fiber is, and they just have different ratios. So some foods that tend to have more soluble fiber are things like oats and barleys for your grains, all of your beans, and then a handful of different veggies and fruits there. They looked at plant protein. In particular, the original trial was with soy products. Other subsequent trials have looked at all kinds of plant proteins and sort of liberalized a little bit, and they've seen similar reductions. So we don't know if that it's specific reductions in soy or just plant proteins, and then you're not getting as much animal products. This 42 grams of nuts, it's about a handful, so throw it in your oatmeal or on a snack. And then this stanol sterols, I wanted to explain very briefly. So plant stanols and sterols are chemically very similar to cholesterol, animal cholesterol. And so what they do actually, they're naturally found in all plants. And when you consume them, they actually block, in our intestines, we have a little transporter. And because they're so chemically similar to regular cholesterol, they block the uptake of cholesterol in our intestines. They actually also block our body's bile salts, which is our body's way. We actually make a lot of our cholesterol, and your body tries to recycle it. And if you block it, then you just poop it out instead. It's hard to get very much plant stanols and sterols in just regular food consumption simply because they're fairly low quantities. So in that trial that I mentioned, they actually had them consume fortified products. Most people take them in supplements and things like that. Always check with your doctors first, but that's how they did it in the trial. Other things about increasing your fiber, just these are a couple of my top tips, things that I end up talking to my patients with and kind of helping them troubleshoot to really ramp up that fiber intake. The biggest take home is if you're not eating a lot of fiber, don't go home and eat 50 grams of fiber. You will not feel good. So start very low. I have them just kind of gradually ramp things up. Increase your water, your hydration as well. Let your microbiome adjust to process all of this fiber. It's definitely one of those cases where you want to not do the marathon and just kind of really go slow. Some of my other tips of getting things in, I mean, you can read a couple of these, but different things I love. Swaps are great, so if you can think of more whole grain or bean versions of products you're already using, that's a great way to get more fiber in and get the refined products out. Keeping skins on whenever possible, so I have a veggie thing, like I roast my carrots with the skin on, anything that, not bananas, but anything that you can keep a skin on, try to do that. Tends to be where a lot of fiber is. Chia seeds and flax seeds are awesome packed little things of fiber, and omegas in some cases. So I throw those in smoothies. I make my oatmeals with them. You definitely can get a lot of fiber that way. What else? This is a really big one that's super confusing, probably intentionally so. So when you're looking at, we're always, most of us, going to have some processed food in our diet. I'm not at home making my own bread. I wish I was, but I buy it. So when you're looking at the food label, it's really important to look for that first ingredient being a whole grain. Something like wheat flour kind of sounds like a whole grain. It's not. It's an enriched flour. So it has to say whole wheat flour. And that's super confusing. And in fact, some of the multi-grain ones that look super healthy, if you look at that first ingredient, it's an enriched flour. So do your best to try to kind of read those labels and get past some of the marketing. Other two things that I like to highlight quickly because a lot of people don't know this. So coconut oil, it had its moment in the sun. It's a healthy fat. It's an MCT. It doesn't raise our cholesterol. We have enough RCT data to show it really, unfortunately, it does. It behaves in our body like another saturated fat. I'm not saying you can't ever use it, but just know that it shouldn't be regularly used in cooking. So whenever possible, using things like extra virgin olive oil or avocado oil are better choices. And then, use that on occasion with baking or whatever. But it definitely raises cholesterol pretty profoundly when used regularly. Coffee is the other one that some people don't know about. So coffee has a compound in it that's cholesterol-like. In some people, it can, if you do like a French press and let the coffee grounds sit and then drink them, it raises cholesterol. Not in everybody, but in some people. So if you have high cholesterol and that's the type of coffee you drink, you can try and experiment and switch it out. The filtered coffee, so anything with a filter, it filters out that compound, and so you don't get that LDL raising effect.
What about espresso?
Great question. I think, I don't know the answer to that. I've been asked that before. Right, so I think it's okay, and that's been my answer. And the other question I get a lot is the pods. With my research, supposedly the pods have a filter in it, so we think they're okay. But there hasn't been a trial with the pods. Okay, hypertension, we gotta talk about high blood pressure very quickly. As probably most of you heard a couple years ago, the blood pressure guidelines changed, so now really we define high blood pressure as anything greater than 130/80. Interestingly, we really do see kind of this continuous graded association with increased risk of particularly stroke as you get your blood pressure up any higher than 115/75. So really the lower the better, for the most part. I love this. This is from the AHA, so if you do check your blood pressure at home, I have all my patients who have high blood pressure do home BP logs because I love seeing those home blood pressure logs. We've got great data that they're a great way to monitor blood pressure. If you do check your blood pressure at home, take a peek at this. It's important that you're in the right position, you're seated for 5 minutes, you're ideally relaxed, all of these things, because they really do affect blood pressure. In terms of lowering blood pressure, a lot of what I want to focus on is diet, but I want to also say that things like exercise, and in the case of blood pressure, stress reduction, alcohol for sure, and weight if necessary, are actually very impactful for blood pressure lowering as well. So diet-wise, I promised you guys I would come back to the DASH diet. Here it is. I want to spend a little bit of time on it. This is the original trial that was published in many decades ago and was just quite, again, one of those big groundbreaking nutritional trials. So essentially what they did is they noticed, again, people eating more plants tended to have a lower blood pressure. Why is this? And so they decided to put it to the test in a randomized controlled trial. So a lot of people talk about the DASH diet, but I wanted to bring you back to the original trial and what it actually included because it was pretty interesting. So the controlled diet is the one on the top. They had the highest blood pressure. They ate, a standard American diet. Actually, the middle one, which they defined as fruits and vegetables in those little hashes, essentially what they did is they had that group eat some more fruits and vegetables, a little bit less sweets, but they were still eating the same sort of meats and oils. And in the trial, if you look at what they were eating 2 servings of red meat a day and 5 servings of like oils and dressings and things like that a day. So, and then what's interesting is then the bottom, so really this DASH diet is eating more fruits and vegetables, eating a little bit less sweets, and then swapping in all those red meat products for more lean meats and things like that, as well as dairy. So, so they increase their dairy, their low-fat dairy, increase their fruits and vegetables, increase their lean meats and other lean sources of protein. And this dramatically lowered blood pressure in people who were normotensive. It lowered it by 5.5 millimeters of mercury. People who had hypertension were lowered by 11 millimeters of mercury. Really big difference. And so this is really the first-line therapy. If you're diagnosed with high blood pressure, your doctor should be putting you on a DASH-style diet, unless, of course, it's super, super high and dangerous. Interestingly, this is without the salt intervention. So I'll show you the salt part in a moment. This is just changing the food. So salt is obviously also very important. I will say that from these Mendelian randomization studies we have, which is basically we look at your genetic predisposition to certain things and then divide you into different groups based on that. Some people are very exquisitely salt sensitive, some people less so. So some of this may not apply to everybody, and we aren't at that place yet where we can say you are or you aren't, other than through experimentation. But in general, salt does increase blood pressure in most people. The average US salt intake is astronomically high, despite anything over 2,000 milligrams really is associated with increased risk of hypertension. So getting back to the DASH diet, when they really restricted sodium down to 1,500 milligrams, they got an additional 12 millimeters of mercury of blood pressure lowering in those hypertensive individuals. 1,500 is really hard to get to. 2,300 is a little bit more realistic for most people, and they saw good reductions with that level as well. So practically speaking, what do all of these things mean? So certainly following a DASH style diet, as I mentioned, so higher in lean meats, higher in sort of dairy or plant-based alternatives, and then lots more fruits and vegetables. Other things that have emerged in the literature since that DASH trial are specifically focusing on foods that are high in nitrates and high in potassium. So potassium has a transporter in our body relation to sodium, and so we think that that ratio is quite important. So focusing, as long as you don't have kidney disease, you want to focus on higher potassium-packed foods. Bananas being the classic example, but I've listed a couple more here that tend to be very high in potassium. There's been a lot of interest lately with nitrates. So nitrates get converted in our body to nitric oxide, which are vasodilators. They really open up our blood vessels, and so there was some great data that getting about a cup a day of green leafy veggies, which is a good source of dietary nitrates, was really helpful in blood pressure lowering. You can also get that with beets and beet juice. So I don't know if you've heard people that are very athletic and really into sports performance go for the beet juice because of this nitric oxide effect. Decreasing alcohol, this is one of the instances in which really making sure you're not drinking more than the recommended amount is important. As well, not just for overall heart health, but really for blood pressure lowering, and then the sodium that we had mentioned. So I want to spend a little time on the sodium. So really trying to get less than 2,300 milligrams a day if possible. That's a teaspoon. It's not very much. That said, it's not really the salt you're cooking with, it's the processed foods. So almost everybody gets, it's like 3/4 of our sodium intake for the average person is from packaged foods. So just being mindful of what you're consuming, reading nutritional labels, and opting for lower sodium versions. This is what the AHA identifies as kind of the salty 6, so the top 6 causes of higher salt in the average American's diet. In my patients, really what I end up seeing is breads for sure. Any frozen entrees are going to be super, super high in sodium, or canned foods. The other ones also that are super sneaky are condiments, dressings, sauces. There's often a lot of sodium in them, but there are brands that don't have them. So it's just a matter of kind of flipping labels and making different choices. The pink Himalayan sea salt, I know it's very popular. I use it in my kitchen. It's beautiful and pretty, but it's just still sodium. So just be mindful of that. And then the spices thing, as I said, it's really not kind of what we're cooking with. It's what we're eating in processed foods. But if you are trying to cut it down in your cooking as well, using additional spices or the potassium salt substitutes, if it's been okayed by your doctor, can be helpful as well. Okay, so I know I've talked a lot about processed foods and it's getting exhausting, but I did want to just show one slide that really kind of highlights the difference between eating more of a whole food plant-based or plant predominant or any sort of whole food diet as opposed to one that's very high in processed foods. And I like this one because a lot of people think a vegan diet is inherently healthy. And really what they saw was that they divided this cohort up into people who were eating a fairly healthy whole food plant-based diet versus people who identified as vegan but were eating a lot of refined grains, sweets and desserts, juices and sugary drinks. And then they did potatoes, I think French fries and potato chips and things like that they wanted to capture. So unsurprisingly, the people who were eating more of a whole food diet decreased the risk of heart disease, and those who we're eating the unhealthier, more junk food diet, was associated with an increased risk of cardiovascular disease. So, as you're trying to make changes, it's all about what you're substituting something with, right? We don't eat food in isolation, it's what are you eating instead, right? Okay, a couple last things on food. Added sugar. This is a huge issue, obviously, right now in our country. We're all eating way too much sugar. In terms of just kind of physiologically, how our body processes sugar differently than in things like fruits. There's never been a single study that has shown that people that eat 5 servings of fruit a day have an increased risk of type 2 diabetes. Sugar that's inherent within the whole fruits, not juiced fruits, but whole fruits have a lot of fiber that we were talking about, that really modulates that glucose spike. So the fiber holds on to that sugar, and it doesn't give your small intestines the chance to suck out all that sugar, right? It really takes it all the way down to your large intestine, and then the microbiomes can handle it. So really, we don't tend to see, this is in general, we don't tend to see those big sugar spikes. Added sugar is different, right? There's nothing else there, and so it just shoots up our glucose. So these are the limits the AHA recommends. Again, the culprits, typically a lot of the processed and packaged foods. The ones I like to highlight for my patients that are sneakier, yogurts, any of the flavored yogurts are a really, really big source of sugar. Again, those sauces, condiments, and dressings, the granolas for sure too, and other sugars. And then when you're looking at labels and things like that, it's very popular now to have no refined sugar. So things will be sweetened with things like honey and maple syrup and coconut sugar and these things. These still are sugar again. And so we just have to kind of be mindful of, again, the food industry using words to get us to think it's healthier. Again, not saying don't ever buy those, but just do so mindfully and knowing kind of what you're eating. Heart healthy fats, so again, we used to sort of think we needed no fat. That turned out to be wrong. We do need some fats. The poly and the monounsaturated fats are the ones that are really strongly associated with reduced risk of heart disease, right? So we saw in that Preventive trial, the Mediterranean diet that I mentioned, where we added fats into the diet and we saw a lower risk of heart disease. I wanted to highlight the omega-3s. Those are a type of polyunsaturated fats, and those are essential, meaning our body can't make them. And so you can get those, so that's where fish comes in. You could also get some ALA, which is a short chain fatty acid, in flax seeds, chia seeds, hemp seeds, pumpkin seeds, and walnuts. And then in terms of just supplementation, because I always get asked about this, the data is very inconsistent. One year we'll get one study that says we need it, and then the next year it's not helpful. So it's really a case-by-case decision. In my plant eaters, I do encourage algae oil just because I don't think that they get enough. If you are an omnivore, I think the data is really mixed. Sometimes I measure omega-3 levels in my patients and kind of make a decision that way, but that's really something that's case-by-case and individual basis. So exercise, also very important for our overall cardiovascular health, and really the guidelines focus a lot on aerobic exercise. So aerobic exercise is the kind that we think of as exercise, where you're getting your heart rate up, you're getting a little bit short of breath. The research has really shown that getting at least 150 minutes of moderate intensity exercise per week is optimal for heart health. We continue to see robust benefits all the way up to 300 minutes of moderate intensity exercise a week, or the vigorous exercise you basically can kind of more or less cut it in half. So 150 of moderate is the same as 75 of vigorous, and I'll show you what that correlates to in actual exercise activities. Importantly, a couple points. Research has definitely shown that you can break this up how you want. So if one day you have 10 minutes, do your 10 minutes. That's great, and then do the 40 the next day, and then however it adds up is great. So there's no like, I have to, 10 minutes is probably the lower end that you could do to get that, but if 10 minutes is what it is, do it. Again, going beyond 30 minutes per week may be some benefits, but you start to really get this plateau effect, and then with elite athletes, we start to see sort of an increased risk. Most of us, however, on the other end of the spectrum, just trying to get what we can get in. And so I also wanted to highlight, we have a lot of robust literature to show that even if you can't hit these targets, doing something is better than nothing. So, so even if you're just at a time in your life where it's just not happening, doing what you can is still great. And also kind of tying into that, and I'll speak on this in a moment, but trying to not be as sedentary. So even if you're not getting formal exercise, trying to kind of get up in between activities is also associated with a reduced risk of cardiovascular disease. So aerobic activity, so interestingly, so I talked about the moderate and the vigorous, so I just wanted to highlight what exactly that means for you in actual exercise terms. So moderate is actually like a really brisk walk. That's moderate exercise. Or slowing at a really, slow bike, casual bike ride, or active yoga class. That's considered moderate intensity. So anything you're doing above and beyond that, so a super, like getting on the Peloton bike, for instance, or running, that's likely in that vigorous camp. So you may be getting more than you think you are. Okay, the other thing I wanted to highlight, because it does not get enough airtime and is quite important, is that of resistance training. So the benefits of resistance training in non-cardiovascular risk areas is quite robust in terms of improving strength, although I would argue that that then translates into mortality issues, because the number one predictor of mortality is frailty, and grip strength is the best measure of that, right? So trying to protect our muscle strength as we age is very, very important, and preventing muscle wasting or sarcopenia. It's also really important for bone health, which is obviously incredibly important for women and a big issue for us. In terms of the heart health benefits, we don't have a lot of heart health hard outcomes in terms of resistance training, which is why it doesn't make its way into the ACC/AHA guidelines. All other guidelines do include it. However, we do have very strong evidence in a number of secondary endpoints, things like body composition. So what I referred to earlier, that visceral fat, programs, we have a lot of good randomized controlled trials that show that programs that include that resistance training in addition to the aerobic training actually result in more favorable body composition outcomes. So you lose more of that visceral fat, which is really important. We also have evidence that this resistance training is very complementary to aerobic training for blood pressure control. So the weightlifting and other resistance training has independent blood pressure lowering effects from the aerobic training. So if you're someone looking to lower your blood pressure, it's a great idea to try to fit that in as well. And then lastly, glucose control. This data is extremely robust. So actually in the diabetes guidelines, resistance training is included as something that individuals with insulin resistance, prediabetes, or diabetes should include. And so this is actually from a trial where they took patients who had diabetes and put them on different programs, and they found that the individuals who just did the resistance training actually had pretty amazing hemoglobin A1C reductions compared to those who just did kind of an aerobic training. And this is also why if you eat a big meal, it's a great idea to go for a little bit of walk afterwards, because that helps to really, again, modulate that glucose spike. So hemoglobin A1C is a measure of your glucose over 3 months. And so it's how we sort of figure out if someone has diabetes or doesn't have diabetes. So if your hemoglobin A1C is above 5.7, that's pre-diabetes, and above 6.5 is considered diabetes. And then lastly, on minimizing the sitting, as I mentioned, a sedentary lifestyle is associated with an increased risk of cardiovascular disease and all-cause mortality independently of anything else. Risk really seems to emerge in the literature if you sit for about 8 to 10 hours in a day, which unfortunately a lot of us end up doing with kind of our work schedules. Interestingly, even in those of us who get how much exercise we're supposed to get, this relationship maintains. So even if you're getting in your 30 minutes like you're supposed to every day, if you're sitting at your desk the rest of the day, that risk still kind of persists. And so really where it's at is maximizing something called non-exercise activity thermogenesis. Basically, that's just a fancy way of saying any movement you do that's not formal exercise, that's neat. And those are great ways to really minimize the sitting as much as possible. So things like many of these things you've probably heard, park your car a little bit further, take the stairs, things like that. Breaking up your work day and doing small little errands, whatever you can do. One of my favorite ones that I've started doing a lot is I meet colleagues for a walking meeting. So, you know, we meet at the park and we talk about what we need to talk about, or even if I'm on the phone with someone, I'll try to get up and walk, even if it's just pacing in my room, just so that I'm not always at my desk. Obviously, there's a lot of activities I have to do at my desk, but for ones you don't have to, you can think of different ways to kind of mix it up. So lastly, I know I've given you guys a lot of information, and I have probably another couple hours worth of it in me, because we didn't even get to some of the other stuff, but I didn't want to overwhelm you completely. But lastly, what I would just say is just, you know, taking some of these things, starting slow. You know, research has really shown that you want to pick just a couple of things to work on at a time to really create lasting, meaningful, and sustainable habit change. So what I work on with my patients that you guys can do on your own is creating these SMART goals. What those stand for, basically, it's specific, measurable, achievable, realistic, and time limited. All of that stands for, basically, I'll give you an example. Instead of saying, I'm going to eat more vegetables, which is super vague and like doesn't really help you, right? I will have green leafy veggies 3 times a week at lunch for the next 3 weeks, right? So it's a very specific goal you know you're going to do, and you can hold yourself accountable and you can check it off or whatever it is. So research has really shown that kind of creating those very specific goals for yourself are the best way to kind of create habit change. Other things you can do are habit stacking. So if you want to do something, tie it to something else that you already do, right? So I want to start meditating. The best way to institute that into kind of your lifestyle is I'm going to do it right after I brush my teeth every night, because you always do that every night, right? So, and then just kind of working on things, as I mentioned, just like little swaps here and there. Go for the low-hanging fruit first, right? I already like pasta, I have it every Thursday. I'm gonna switch it to bean pasta or whole wheat pasta, right? So just little things that you can do throughout really kind of add up. I wanted to highlight also a app based, speaking of SMART goals, that I am the advisor for. It's free. It's called PlateUp, and we just launched it. It's very much in its alpha version, so it is a baby. We only have about 1,000 users so far, but if you wanted to check it out and give us feedback, let us know. Essentially, what we're trying to do is help you log your food, create meal plans. There's an kind of explore page, so there's a social media aspect to it. You can follow other different experts who are on there with their recipes and meals, add those to your meal plan, get inspired. You can track your health metrics. Eventually we will have sort of a way where you can interact if you have a doctor or a health coach or a nutritionist that you're working with actively. You can interact with them on the platform. They can see what you're eating and make suggestions and things like that. So feel free to check us out. I have the team create a QR code, so it's, I think, on the next slide. Yeah, it's right there. So that's a QR code. Hopefully it will work. So thank you guys so much. This has been amazing. I loved chatting with you guys. I look forward to your questions. If you want to hear more of this type of stuff, I'm very active on Instagram. I post lots of heart health tips and stuff like this. And then I, as Jan mentioned, I am a preventive cardiologist. I'm here in the Bay Area. I've been doing telemedicine up until very soon. I'm finally going to go brick and mortar, so I will be available for appointments in San Francisco as well. And yeah, I want to hear questions. What do you guys have for me?
How do you know if you have fat around your organs?
Okay, so the question for the virtual audience, how do you know if you have fat around your visceral organs? So the best way to look for that, so that's why the waist circumference is a big one that sometimes some doctors will measure, is check your waist circumference. It's not the best test. The gold standard is something called a DEXA scan, which you might have had done for your bones. There's a different DEXA that they can do to look for body composition. So that's the gold standard. It's what they use in research trials. And actually a fair amount of people do those. If you wanted a test that doesn't involve any radiation at all, there are body composition scans that you can do. Probably the most famous ones like the InBody or things like that. And so they sort of can figure out where fat is and if you have any visceral fat and what amount. Yes?
Do you have any tips or thoughts about helping us to understand the role of triglycerides in the bloodstream? Because like my husband's, his triglycerides are always just kind of a little bit higher, but and the doctor likes, but not enough to put him on anything, you know, pharmaceutically.
Okay.
I mean, he is bringing it down, but it's kind of a confusing topic when I search to try and do research on it, and it's, you know, is it coming from our high omega-6s, or is it coming from that glucose connection you mentioned? Because he's a pretty healthy eater. It might just be a genetic thing, but I know it's a precursor to cholesterol, right?
So the question
Like a building block, or?
So the question's about triglycerides. How important are they? What are they? How can we lower them? So I actually just wrote a blog post on this, and I'm about to post it on social media soon. So yes, so triglycerides are increasingly being recognized as a cardiovascular risk factor. So LDL is still sort of the primary target, right? But we do know that there is residual risk with elevated triglycerides, even in those who have their LDL under control. So in general, the guidelines are get the LDL under control, and then if the triglycerides remain elevated, focus on those. So triglycerides are fats, basically. They're fatty acids attached to this like glycerol backbone. Where they come from, they can either come from the fats we eat, and so they get packaged in chylomicrons, but really the majority of our triglycerides that when he gets his blood test, it's coming from the liver. So those are packaged in something called VLDLs. It's another particle. It's the precursor actually to LDL that come from the liver. And when that production goes into overdrive, it can happen in certain settings with medications. So steroids, beta blockers, there's like a whole list of medications that can do it. Genetics can be a component, certainly. And in many people who have moderate to severely elevated triglycerides, there's definitely a genetic component to it. But the vast majority of cases in the United States is insulin resistance. So really what happens is insulin does a number of things, but it is also responsible for ensuring that our fat cells don't spontaneously release fat. So they keep it in there. And so when you're no longer as insulin sensitive, any adipocytes you have or fat cells release the triglycerides into the bloodstream. Those go to your liver. Your liver packages this up into VLDL, and then they come out. And research has really shown that triglycerides do increase risk of cardiovascular disease. It's not the triglycerides themselves likely, it's these remnant particles. So what happens when you get tons of these VLDL particles, they start to get processed and processed and processed. And so in general, as I mentioned, the biggest sort of atherogenic lipoprotein in our bloodstream in a normal situation is LDL cholesterol. But when you have insulin resistance or lots of VLDL in your system, what actually ends up happening is you actually have a lot of these remnants that also contribute to risk. So the VLDLs will break down into these things called IDLs. Eventually, they do break down into LDL. And so what it is it's those particles, those IDLs and the VLDLs that end up depositing cholesterol into our arteries. So that's sort of that relationship. In terms of lowering triglycerides, some of the best things you can do is working on the insulin resistance piece if there's a sign of that. So the first sign of insulin resistance is an elevated fasting insulin, followed by an elevated fasting glucose, followed by an elevated hemoglobin A1C, that thing I mentioned. Most of the time we're picking it up when the hemoglobin A1C is really high. That means disease is already set in, right? It doesn't mean that we can't reverse it, but ideally we pick it up a little bit sooner, right? So if the fasting insulin or the fasting glucose are elevated, then the first steps are working on that insulin resistance piece, which means cutting down the refined carbs, cutting down the sugars. Alcohol is a really big one too, and then increasing the resistance training.
All those fast sugars will go right in.
Yep, exactly. Yeah. Sorry, that was a really long-winded way. I'm very passionate about this. Yeah.
Are egg yolks still out, even if it's
No. So great. I'm nodding because yes, that is an excellent question. I get that one a lot. So the question was about eggs. Are they bad? What about the egg yolks? So eggs are really interesting. So when you do a lot of these swapping analyses, like I showed you in the beginning, they tend to be still associated with increased risk of cardiovascular disease. Not always though. So that one, not always. The processed red meat is like always comes out on top, right? Eggs are a little bit less consistent of a relationship. Certainly we don't have a lot of data on egg yolks versus egg whites, right? So just consuming egg whites in my patients, it depends on kind of all of their risk factors and things like that, and what our goals are and what we're trying to accomplish, but certainly some amount of egg whites is likely okay. The egg yolks, as you probably know, are the part that has a lot of the cholesterol in it. Cholesterol, again, kind of goes back and forth in terms of does it raise our blood levels of cholesterol? So by far, the biggest dietary source of raising our blood levels of cholesterol is the saturated fat, as I mentioned. Dietary cholesterol does increase LDL in some people, not in everyone. Interestingly, it's actually, there is a plateau effect. So it's people that don't eat that much cholesterol that dietary cholesterol may actually impact it. So the long way of saying, I prefer my patients not have more than a couple eggs a week if they're consuming the yolk. The egg whites, I think, is kind of a case-by-case different story. The other time that sort of eggs get mentioned is the choline. So I mentioned the gut metabolite, TMAO. So if we consume a lot of carnitine and choline, which are in kind of animal products, our gut microbiome turns that into TMAO, which is a metabolite, it's a byproduct that has been associated with increased risk of heart disease. It hasn't been firmly established as causative, so it's something I kind of look at and measure, but I'm not, super aggressive about it. But it's something to kind of be aware of as maybe an emerging risk factor associated with something like eggs, right? But I would say, in terms of different sources of protein and things like that, it's, especially if it's just the yolk, if it's just the whites, that's a reasonable source, yeah. Yeah.
So, in our family, we're lactose intolerant.
Yeah.
I know a lot of people that are. And
Yeah.
Substituting, of course, the plant milks, but also the non-dairy cheeses and whatever. And it seems like that's very high in salt. And I don't know what your recommendation is about which plant-based milks are better than these cheeses.
Yeah, so with the plant-based milks, most of my patients, unless they have a issue with soy, I recommend an unsweetened plain soy. It's really equivalent to a cow's milk in terms of protein, and as long as you're getting it unsweetened, it's not full of sugar and things like that. So that's my typical recommendation there. The other ones are fine, they just don't have very much protein in them, and I do think for LDL reasons and all other kinds of reasons, protein actually is important. I think you do need to kind of pay attention to it. In terms of and then same with the yogurt, so there's some plain cashew ones and soy-based ones as well. We can get into soy if people want to know. It's not bad for you, it doesn't cause man boobs. That was a big thing that was around on social media for a while. In terms of the cheeses, they're hard. So I don't love a lot of the cheese alternatives simply because most of them are coconut milk, are made with some sort of coconut oil. And so they're very, very high in saturated fat as well. There's some that are more cashew-based, and so those tend to be okay. And the sodium content does vary, so you do have to kind of be mindful of that. So in general, I don't do as much replacing of the cheese with plant-based cheeses. Usually it's like, okay, so what are you trying to accomplish there? Can you do like a creamy cashew sauce instead, or nutritional yeast, or is it just on a sandwich and you just need some creaminess? I spread avocado, So I kind of do some of that, and then the occasional cheese, right? If you consume dairy, if you're lactose intolerant or don't consume dairy, obviously that's tougher. I have so many questions. Yes.
There's a question from the Zoom audience.
Yeah, let's do that.
Can you speak to the large, fluffy LDL particles versus the small particled LDL? If one has a predominantly large, fluffy, and no other risk factors, do you feel a statin is still warranted?
So the question was about LDL cholesterol. Is there a difference between sort of the large, fluffy or the small, dense LDL? Actually, interestingly, that does get back to our earlier conversations about insulin resistance and triglycerides. So in general, So backing up how to explain what this is and what this means. So as I mentioned, really it's that LDL cholesterol particles, or that concentration that's associated with an increased risk of heart disease. When you're getting a blood test from your doctor, that standard lipid panel, it's actually, when you get that LDL cholesterol, what LDL cholesterol they're referring to is measuring the amount, or estimating rather, the amount of cholesterol contained within those particles. Now, so you can have an LDL cholesterol of 130, and I can have a LDL cholesterol of 130, and we can have vastly different numbers of particles. So say we have LDL 130, that can be contained within 5 large fluffy LDLs or 10 small dense LDLs, and that LDL cholesterol will be the exact same. So what we've seen is in that people who have the small dense LDL cholesterol, this is why I like measuring something called ApoB, or LDL particle, because what it does is it actually counts the number of particles instead of estimating the amount of cholesterol inside. Because then you're capturing those people who have a lot of this small dense LDL. And studies have really shown that in individuals who have sort of that discordant pattern, meaning a high particle number, their risk of cardiovascular disease is much more closely associated with the particle number rather than the LDL cholesterol. So there's a lot of debate as to whether or not it's those small dense LDL particles that are worse than the large fluffy, or if it's just that they have more and so the concentration's higher. Either way, I like that particle number to be lower, or the ApoB to be lower, however you want to call it. ApoB, apolipoprotein B. So that's a blood test you can get. Both Quest and LabCorp do it. And it's a good way, and lots of people, particularly if you don't have any signs of insulin resistance, those numbers are pretty concordant, meaning that you get your ApoB, and it's about what you expected based on your LDL cholesterol. So in that case, it's not like you have to keep following it. But in people where you're like, whoa, that number's a lot higher than I thought it was going to be, then I follow the ApoB, and that's my target.
Yeah.
Can you help us understand the calculation that my doctor seems to make, which is she looks at my cholesterol, but then she looks at weight and age and blood pressure, and then says, you're fine, no intervention, even though my LDLs are crazy high, genetically.
Right. So, so she's probably looking at the ACC-AHA 10-year risk calculator. So the question was, in the setting of elevated LDL cholesterol, how can we think about that, and is there a risk calculator that my doctor's doing? So, so that 10-year risk calculator is a great way to assess population-wide risk, right? And it's quite accurate in some cases, but falls apart in a lot of people, unfortunately, which is why there's all these other risk-enhancing features like family history and things like that. And so sort of based on the guidelines, as long as your LDL cholesterol is below 190 milligrams per deciliter, then you can use that calculator, which, as you said, it takes into account your age, your gender, your blood pressure, your HDL, your total cholesterol, if you've ever smoked, if you have diabetes, and then it spits out a number. And that percent is your risk of having a heart attack or stroke over the next 10 years. It'll give you kind of a low risk, which is anyone, arguably less than like 5%, intermediate risk, high risk, super high risk, greater than 20%, yada, yada. And then based on those numbers, should you prescribe a statin or not? That calculator falls down in a number of different ethnicities. It also really falls flat in young people and in women a lot of times, I have found. So a lot of times what I'll do is if I'm seeing someone who has sort of a cholesterol number that I'm not loving, I'm not excited about, but they don't technically fall in a statin risk category, a great way to use to kind of figure out further what you want to do is some sort of diagnostic test. So a coronary artery calcium score is something that many of my patients find useful. It's essentially a specialized type of a CAT scan that looks at your coronary arteries. Many of us in the preventive cardiology field kind of refer to it as like colonoscopy for the heart, if you will. It has a number of downsides, but it has a lot of great data behind it, and we have decades worth of research at this point showing that it can really help better risk stratify people who, if you're on the fence about whether or not they need a statin or not. So usually I try a lot of different, dietary strategies and or some of these supplements and things like that to get LDL cholesterol down, and then also, try to do some sort of additional risk assessment. So the coronary artery calcium score, it's as I said, a specialized CAT scan, so it does require some radiation, although most of them are protocoled down to kind of less than a mammogram at this point. So, a lot of us are getting mammograms and things too. So it's, but again, it's not something you want to do every year. It's radiation, right? So yeah.
Is that the only, you said there's a number of downsides, right?
So yeah, so the radiation exposure is one. The other one is that it's picking up the calcified plaque, right? So it cannot pick up the soft plaque, and I think I took the slide out, but basically plaque sort of progresses from the initial cholesterol deposition, and for many years it's the soft plaque. It's just a little bit of cholesterol in it. And then over time it starts to harden. And so calcified plaque, even though we refer to it as the colonoscopy of the heart, it actually is picking up old-ish plaque, if you will. So you do have to be careful in younger people that you're not like, you're all clear, there's nothing there, because, younger people, I would expect it to mostly be soft plaque. That said, as I said, we have decades of research showing that if you do get a coronary artery calcium score of 0, the odds of a heart attack or other cardiovascular event over at least the next 5 years is very, very low. So it can kind of help you be like, okay, I don't love where these are right now, but risk-benefit wise of a statin, and let's check in again in a couple years kind of thing. So that's how we can use it. The other test that we're starting to use a little bit more is something called a CT angiogram. So essentially it is a CT scan that you actually put dye in and you do a type of an angiogram basically, but not invasively. That allows you to identify soft plaque as well. The big downside of that, obviously you need dye, so you need to get an IV. A lot of times they have to give you a medicine to slow the heart rate down so they can get a good enough picture. A lot of the payers, unless you have symptoms, won't pay for it. So I have a symptom. But the coronary artery calcium score is much cheaper. They often don't pay for it, but it's usually like $100. The CTAs are a lot, unless you have a symptom. And it's more radiation than the coronary artery calcium score, certainly. So a lot of us now, so it was mostly previously used just for symptomatic individuals, and it's starting to move its way into the preventive sort of literature. A lot of us use it now in kind of our particularly younger women who were particularly ones with family history that we're worried about.
Let's say younger woman. Like someone who turned 40 today, would she still be considered?
Very young, yes. I'm a cardiologist. Yes.
Her mom had a heart attack when she was 47.
That is my classic patient where I get one of those. I as a preventive cardiologist, I tend to see lots of 40, 50, 60. Those are young for me. And those are the type of people that I really like to get aggressive and early and check on early. Because those are the people that tend to surprise us sometimes. So those are different things to do. There's also something called a carotid IMT, which is a special type of an ultrasound. And obviously the benefit there is there's no radiation. You're not looking at the heart, but atherosclerosis, as I sort of showed you, is a systemic thing, right? So most of the time, I've had a couple of patients that shocked me, but most of the time, if you have deposition in one arterial bed, you'll start to see it in another one, right? So it's a good, very non-invasive, like literally no risk way of kind of following things. And so basically we can measure the thickness of the artery wall and compare that to age and gender match controls, and it starts to get thicker as things are starting to build up. The biggest downside of that is that in research it performs beautifully. In the community it falls down simply because it takes skill, and if a technician isn't doing it correctly and really being mindful of the test, they'll just take a picture and you don't get a great number. So you really want to go somewhere where they do a lot of them and they're being mindful of it. But that's a great way. I mean, my practice in New York and what I'm hoping to replicate here, I used to follow all my patients with a yearly IMT because I had a great tech and I knew she was doing a really good job. So, and then that's another good way if you're starting to see changes there and it's a true, the next over 2 years you really see that going up, that's another good indication maybe we want to do something sooner than later.
If your calcium score is high, to her point, and then you have that hardened
plaque? Is it reversible or are you done for?
So not done for, not done for. So the question was about if there was a elevated coronary artery calcium score, is that permanent? What can we do about it? So it's interesting. The calcified plaque, as if you recall from the very first slide, isn't usually the plaque that causes us problems. So when people have an elevated coronary artery calcium score, it's really the associated soft plaque that we're not actually measuring that's likely the troublesome stuff, if that makes sense. So it's that early soft, it's these thin, we call it thin fibrous caps, so there's a lot of cholesterol and just a tiny little lining over it that are more susceptible to bursting. So, so those are the plaques actually that we are more worried about. Once they become, so interestingly, if you put someone on a statin and you check their coronary artery calcium score in 5 years, it will likely have gone up. But it's not a bad thing, because what's happened is the statin helped to stabilize those soft plaques that they had, you just didn't see them. And so, correct. So that's why the CAC goes up. So, so a long way of saying coronary artery calcium in and of itself is not never, but not the super bad stuff. It's that soft plaque that we really want to prevent. A lot of that we can delipidate. So when we get LDL cholesterols down really low, 40s, 50s, things like that, we do see some reversal. And statins now, we have enough data to show that, that you probably can get about like a 20% reduction in plaque burden and stuff like that. So it's not that it can't ever go away. But I would also argue that calcified stuff, if I can keep your plaque that you have now calcified and not do anything, right? You'll never know it's there, right? So it's really the stuff we wanna, our biggest goal is to stabilize plaque and not let it get bigger, not let it cause her problems.
So somebody who takes statin and medicine against high blood pressure still should try to change their diet.
Absolutely. So, so I actually just posted on this the other day. So, yes. So even in individuals who say have a genetic predisposition for high cholesterol, or for whatever reason, they're taking the medication. Yes, statins can do lots of great things. Not only do they lower LDL cholesterol and protect you from heart disease, they do lower inflammation and things. They do have other side effects or off-target effects that are good. They can't do everything, right? So, so it's also important to kind of work on lifestyle. I think it's a really strange false dichotomy that's sort of developed at this point, that it's an either-or approach. It's never that. I have lots of patients in my practice who have, familial hyperlipidemia, like very, very high cholesterol levels from genetic reasons. They're on PCSK9 inhibitors. And we still talk about diet at every single visit, and what we can do. Because it's not just about, it's not just, so statins can make glucose worse too, right? So we have to be more mindful of, if you're on a statin, you might start to see the hemoglobin A1C trend up a little bit. So we have to be a little tighter in terms of the refined carbs and the added sugars and things like that. So there's always dietary stuff, and we definitely have data to show that they're complementary, and they work well together. And in all the trials that we do when we're looking at kind of goal-directed medical therapy, it's always on a backbone of a heart healthy and lifestyle approach.
What do you have any input to any wisdom to share about intermittent fasting?
Great question. So I want you to ask me that question in like a year, because I feel like I'll have a lot more data. Right now, it is somewhat of a data, I don't want to say data-free zone. We have more data than we did even a year ago. I think it's still a very interesting mixed picture. We definitely have some data on, so I certainly think, so to define intermittent fasting for everyone, it's defined variably in the literature, or time-restricted eating, circadian fasting. I mean, there's all these different kinds, right? In general, the Salk Institute has a lot of great literature they've put out on circadian fasting. I think I usually start with my patients on making sure they're eating food within a window of time that corresponds to their body's biorhythms and our natural wake and sleep cycle. And so I think that's where the data right now is the strongest in terms of how, because our body naturally, our blood pressure and heart rate and cortisol and all our other hormones, they naturally fluctuate over the course of a day and a night. That's our normal body's response. And so they have a lot of good data that's showing that eating too late into the night, it definitely affects our melatonin. I mean, there's all this different, so it definitely makes sense to kind of try to eat within definitely a 12-hour window. I think probably the 10-hour window is like a great goal for many people. I can't totally always do that, just I think life and kids and whatever it is. But if you can aim for 10 to 12 hours, that's a great sort of way to eat in terms of body composition, glucose, and all these other biorhythms and things like that. So that's more of a time-restricted eating, circadian fasting. So keeping your windows in that time frame. Intermittent fasting, whether you're doing a 2 and a 5, so you have some days where you're eating and some days where you're not eating. There's a lot of research there as well. They've tried a lot of these different things with weight loss, which has been a big one. And really kind of what the data has shown at this point is that intermittent fasting or time-restricted eating isn't necessarily superior for weight loss, but it's equivalent in terms of just pure caloric restriction, and maybe easier for people to do, right? And so it's definitely, if people have tried to lose weight on a pure just calorie restriction diet and it's just not working for them, switching to some sort of time-restricted eating pattern could be a great solution and is for many people. We also have some data, which obviously I'm most interested in, on how does it affect cardiometabolic health, right, and different cardiovascular risk factors. And there's some data to show that it may have independent effects on triglycerides and a couple other metabolic parameters. So I feel like in the next couple of years it's gonna explode, and we're really just getting, and there's so many trials that are ongoing right now. So definitely a field to watch very closely. Yeah.
I was just question about high sensitivity CRP or inflammation.
Yeah.
You didn't really define it, but do you have markers that might be clinically useful and what?
Yeah, so inflammation's a really interesting one, and certainly another area that we're learning more and more about. So we certainly know that in many people who particularly have had a heart attack, for instance, we have a great trial on this. People who've had a heart attack, we get their LDL levels to below 70, where they're supposed to be, everything's looking great. If you divide them into two different groups, so having a high sensitivity CRP that's greater than 2 versus less than 2, the people who have, and a high sensitivity CRP for everybody is probably the best, is definitely the best studied inflammatory marker that we have looking at inflammatory risk. And so the individuals who had an hsCRP greater than 2 had a much higher rate of recurrent MI and things like that. So in the preventive cardiology community, definitely this concept of residual inflammatory risk has started to become really, is in the infancy, unfortunately, of exploring it. A lot of the trials that we've had to date looking at how to lower inflammatory risk haven't always panned out. We need some inflammation, right, to fight infection and things like that. So the key is trying to lower that inflammatory risk, but in the right way. Colchicine is actually an interesting drug that's very old, very cheap, and lowers inflammation. We use it a lot in like pericarditis, so inflammation of the heart sac and things like that. And so Paul Richter, he's the inflammatory guru. He has millions of papers on this, but colchicine, it's actually in the European guidelines. So if someone is of high cardiovascular risk and has residual inflammation, to start colchicine. It's not as much used in the United States, but I think is starting to catch on. There's been a lot of research that's emerging about autoimmune conditions and how that affects risk. I have certainly anecdotally seen that in my patients, people who are younger who have autoimmune conditions and who have premature coronary artery disease. So definitely in those individuals, working closely with the rheumatologists and things like that. So rheumatoid arthritis probably being the one, and psoriasis, those two being most closely associated. Yeah, so gout being definitely an inflammatory condition. So yeah, trying to keep those, so definitely working with a rheumatologist and trying to keep those conditions managed as best as possible and as not as symptomatic as possible is sort of the strategy, plus minus anti-inflammatory sort of approaches. Again, another area we're gonna hopefully have a lot more research coming out. And HSCRP is probably the best marker. We have a couple other ones that we use, but that's still, that's the one I use in my patients. There's a couple other ones, but they're not as robust.
And you can track it, like if it's coming down.
Yep. Yeah, I track it. And, you know, in terms of lowering inflammation other than medications, eating lots of plants is great, all the antioxidants. There was a trial that came out looking at a specific anti-inflammatory diet, and it was definitely low in processed and packaged foods and processed red meats, high in specifically plants. I think they identified like red and yellow vegetables, cruciferous vegetables. Like there were some that really emerged as being particularly anti-inflammatory, berries, and then like coffee and tea, and wine. So things, and extra virgin olive oil. So foods that are high in, you know, polyphenols and stuff. Sorry, Lisa.
Just a little off subject, but I had COVID back in January, and my heart felt like it was being squeezed. Like, and have you heard of that with other COVID? Is that a common?
Yeah, so COVID has been interesting for us in the cardiology community. It definitely, like any virus, you know, COVID may be a little bit worse than other viruses, but I will say, as a practicing cardiologist in New York, every flu season, I had umpteen young people coming in with viral flu, post-flu cardiac symptoms. So it's not unique to COVID by any means, but yeah, COVID and like the flu, we see definitely myocarditis, pericarditis, so inflammation of either the heart muscle itself or the sac that surrounds the heart. And in that setting, definitely have seen arrhythmias or rhythm issues. We have seen POTS is the other big one, so it's an autonomic dysfunction where we see sort of really fast heart rates and kind of feeling uncomfortable with position changes. Lots of young women and young men to a certain extent end up getting that. Most of this has all been, you know, time and all that kind of stuff. Obviously there's some people where they've had residual effects, but yeah, we've had a lot of different post-viral sort of cardiac symptoms. And now monkeypox. We just had our first case of a myocarditis associated with monkeypox. Yeah, not we, but the cardiology community. It was published recently, yeah. So yeah, viruses definitely can affect the heart in lots of different ways, yeah.
So I remember, I don't remember the name of it, but there was an injectable alternative discussed statins. Can you talk about that?
Yeah, so PCSK9 inhibitors. So these are revolutionary. Repatha is one of the brand names, and Praluent's the other one. They are an injectable medication that dramatically lowers LDL cholesterol in the order of 70–80%. And they were actually discovered because of a genetic mutation. There's people that are genetically lack PCSK9, which is essentially responsible for so basically the PCSK9 inhibitors end up not destroying the LDL receptors, so you get clearance by the liver, right? So anyway, so they were discovered because of a genetic mutation. So there's people walking around with their own PCSK9 inhibitors, and they have like no LDL cholesterol, and they basically virtually never have atherosclerosis. And importantly, their LDL levels are sometimes undetectable, and they live normal, healthy, lovely lives with no brain issues. And that was a concern for a while at one point. But your body makes enough cholesterol. So yeah, so those are those medications. They have a lot of trial data behind them at this point that not only do they robustly lower LDL cholesterol, but they also reduce cardiovascular risk. So you're not only are you definitely lowering the LDL cholesterol, you're also preventing heart attacks and strokes. They are very well tolerated. So I end up having a lot of patients come to me who are statin intolerant, and by and large, almost always tolerate the PCSK9 inhibitors. They're injectable. You do them every 2 weeks. Sometimes people get a little irritation at the injection site, but otherwise they're pretty well tolerated. They're expensive. That's the other thing. So you got to get pairs to pay for it. There's coupons. We use a lot of coupons, but yeah, they're expensive. Yeah.
Are they self-injected or you go to the clinic?
Yeah, it's just like a little pen. Okay. Yep.
What's the process? Like, how long is the process? Would you expect to get the LDL lower?
question was, how long does it take for LDL cholesterol to go down? The answer is that highly variable. It depends on where you're starting, what's the intervention, how aggressive are you making an overhaul, crazy change, or is it small little tweaks off and on? To give you a point of reference, the portfolio diet that I showed you, that randomized controlled trial where they changed their diet, the first data point was 2 weeks out. So it can be quite quick with pretty big changes. I normally give people, I mean, that's a research trial where they're like giving them the food and they have a dietitian and, you know, so most people are making kind of smaller tweaks and things like that. So I usually kind of tend to follow people, depending on what we're doing, you know, every couple of months to give people time to really make those changes and those goals. But it can be really quick if there's a really big overhaul. Blood pressure is the one that goes down really quick. So that's the big one to be mindful of if you're making big changes and you're on blood pressure medicines. Always checking in with your doctor about that, because within a week sometimes, you know, your blood pressure can get pretty low. Yeah. So I've had to de-escalate blood pressure meds quickly, yeah.
Do you want to mention on menopause affects all this?
Menopause, good one. I need to do a whole talk on that one, yeah. So, so menopause, as I mentioned, premature menopause is associated with an increased risk of cardiovascular disease. It's that withdrawal. We think it's really that withdrawal of the estrogen at an earlier time point in our life that ends up being increased risk. Certainly the changes that we see post-menopause, unfortunately, are, you know, the cardiometabolic changes are not the ones we would ideally like to see, and it's that withdrawal of estrogen. So in general, for most women, we do see adiposity increase to a certain extent. We do see some lipid changes. Definitely the LDL can go up. Lp(a), which we didn't talk about at all today, but it's another genetic type of cholesterol transporter. That definitely, that's the one time it does go up. So we do see some of this stuff and some more insulin resistance, again, associated with that estrogen withdrawal. Definitely should probably touch on the fact that hormone replacement therapy, it's gone through these like major changes. You know, we thought because, oh, it's the estrogen withdrawal, let's give people hormone replacement therapy, and then that'll be associated with a decreased risk of cardiovascular disease. There was a big trial that came out. It was not favorable. However, you know, in retrospect, the trial unfortunately included women who were more than 10 years out from menopause. They were older than kind of the typical woman. I mean, they were mostly like older than 65, so older than you would typically start someone on hormone replacement therapy. So there were a lot of limitations. And so in general, the pendulum has swung back the other direction, and most of us feel really, really comfortable with HRT in the appropriate patients who are having vasomotor symptoms like hot flashes or whatever else. And the rule of thumb is just, you know, obviously screening for established heart disease or blood clotting issues or things like that, and then ideally starting hormone replacement therapy when you're less than 10 years out from menopause and younger than kind of 65 when you start it. Yeah, so that's a lot of that. Transdermal if possible. And then, you know, some of these, again, it's an area that's fairly poorly studied because it's women, you know. OB, women, pediatrics, we don't get studied enough, but yeah, so not as much data as I would like in terms of what to do about those changes and how to mitigate it, but the little data we do have is that the same lifestyle changes that we've discussed today are still impactful, like in that setting too. Yes!
So follow Nicole on her social media and on her website, and I'm sure you can sign up for PlateUp.
Yeah.
And I imagine you can reach out to her if you have any
Of course, absolutely. Reach out on my website. That's my website. I have my email there. You can always reach out that way or on Instagram or whatever. It was such a pleasure chatting with all of you guys today. I'm so excited people are interested in heart health. Yeah, thank you.